Great to see everybody. Welcome to this great opportunity here today. And we want to just thank our friends from Quest Healthcare for being a great partner for NASCIC, but also giving this opportunity to learn a lot about AD and bowel routines, especially, and some of the products that they're offering. This is going to be, it's a topic that people in the rest of the world don't really understand. But everybody, I think, in this meeting today will be very interested to hear what you have to say. And my understanding is, Margaret, we'll have some time after for some Q&A. If time prevails, that'd be great. So I just want to introduce everybody here. I want to introduce Margaret Swanto. Margaret has been dedicated the past 25 years to the pharmaceutical industry, primarily at AstraZeneca, where she served as the national sales trainer and held various positions in specialty sales for the last 5 years. And she has been the director of education and sales at Quest Healthcare, engaging with national thought leaders, developing and implementing training materials and conducting educational and services. I can say that Margaret is very, very passionate about her work, and it's always a pleasure in speaking with her and her product knowledge. And I think everybody here today will enjoy that. We also have Ryan Gobauer. Ryan is a C3-4 complete tetraplegic. He was injured as a result of jumping out of a tree into a canal 25 years ago at 16 years old. He graduated from Florida Atlantic University with a master's in business administration and is a founding member of the largest SCI support group in Florida, which is the Spinal Cord Injury Support Group of South Florida. Ryan has been working with QuestCare as a national community relations advocate since 2014. And just to mention, this is one of many webinars that we're hosting, and we're very fortunate to have our partners at NASCIC and QuestCare being a partner of the organization, sharing their knowledge with us, and we look forward to hearing from them. So, Margaret, it's all yours. Take it away.
All right, thank you so much. I'm going to share my screen. Can everybody see this?
Yes.
Okay, good. Let me put it in slide mode. Just give me a second. All right. Well, thank you. So the topic today is autonomic dysreflexia, or AD, which we'll be calling it from now on because autonomic dysreflexia is definitely a mouthful. And then we'll also talk a little bit about neurogenic bowel. This is going to be an interactive presentation with Ryan and me. And at the end of the presentation, we will open it up for any questions that you have. So today we're going to go over just a review of spinal cord injury, describe the characteristics of AD, the pathophysiology. So what exactly is really going on when a spinal cord injured individual gets autonomic dysreflexia, identify persons at risk for AD, the symptoms of AD. We're going to talk about preventative measures, bowel care discussion, and locate the resources of treatment for AD. So just some statistics. There are approximately 291,000 Americans with spinal cord injury. 39, almost 40% of spinal cord injured individuals are considered paraplegic, and almost 60% quadriplegic, or the new term right now is tetraplegic. Approximately 17,000 new injuries each year, and 78% of them are new cases of being from, the male gender. So, when you're looking at mean age of injury, it has increased. Back in the 70s, it used to be, in the 20s, but now, because of our aging population, it has increased to 43 years. And when you're looking at male to female ratio, it doesn't matter. Men and women are equally, as far as autonomic dysreflexia is concerned. So length of stay, it has decreased, which is great in both the acute care setting and the rehab setting, because we're learning so much and we have great technology. Ryan, can you talk a little bit about your injury in the acute care hospital setting, exactly what happened and, what happened after your injury in the acute hospital?
Absolutely. So at the age of 16, 29 years ago, I purposely climbed a tree about 36 feet up with the intentions of leaping out into a canal. Upon doing so, I jumped out, and when I hit the water, I did a belly flop, and that's when I severed my spinal cord at the third and fourth vertebrae. I was airlifted to a local trauma center, intubated, emergency surgery, then sent down to Jackson Memorial, where I started going through the acute phases. I ended up going through the acute stage of 3 solid months, receiving OTPD speech recreational therapy, but learning that spinal cord injury wasn't just a physical aspect, it was also the secondary, which is the bowel bladder. And because I'm in between that cervical 1 and T6 level, that also I would be experiencing autonomic dysreflexia symptoms.
Thank you. And I mean, the good news, the majority of spinal cord injured individuals do return home. How long was it before you actually got home from your spinal cord injury?
So from day of injury to discharge was exactly 6 months with surgeries
6 months.
and 3 months rehab.
Yeah, and we can go into some details here as why it was that long a little bit later. So exactly what is autonomic dysreflexia? Well, it's a syndrome characterized by that abrupt onset of excessively high blood pressure caused by that uncontrolled sympathetic nervous system basically response. It's a discharge. Your sympathetic nervous system is your fight or your flight system. And we'll get into a little bit exactly what happens, but it's amplified. True autonomic dysreflexia is potentially life-threatening if it's not dealt with. Morbidity and mortality with hypertension, cerebral hemorrhage, spinal shock, mortality is rare. So AD essentially can occur right after spinal shock. And spinal shock is really what happens immediately after the injury. So there's that sudden loss of neurological control below that level of injury. It can last days or it can last weeks, but eventually your body starts to figure out exactly what is going on. So the doctors and the nurses can basically figure out, how to treat the condition. So let's look at the pathophysiology. So it's a very busy slide, but I did number everything. So hopefully you can follow it through with the numbers. But the reason I love this slide, it's because it really helps you understand what's going on when you get autonomic dysreflexia. So let's start with number 1. You have this noxious stimulus below that T6. The T6 is really what we're looking at. So anything below that thoracic level 6 is really those individuals that are getting that noxious stimulus. So what's going to happen? You're going to have that distended bladder, that kinked or catheter. You're going to have a bowel impaction. You're going to have severe constipation. It could be anything, such as an ingrown toenail, a pressure injury, and Ryan will get into that a little bit. So all of these things, or one of these things, may be going on. And so what happens? So it sends these signals that travel up your spine, but they're blocked at the level of injury. So it can't get any further. So unchecked, that sympathetic fight or flight system chain causes vasoconstriction. So you're going to get narrowing of those vessels below the level of injury. So those vessels are lowering. But then what's going to happen? That vasoconstriction or that narrowing is going to cause that blood pressure to rise. So that elevated blood pressure in number 4 is sensed by your carotid and your aortic baroreceptors and transmitted to that brainstem. And then after that, what's going to happen? Well, the body tries to create a homeostasis. So what it's going to do, it's going to send that parasympathetic response down, but it can't get below that level of injury. So that parasympathetic is your rest and digest. So it's trying to calm everything down. So it can't. So what happens? This leads to that slow heart rate, vasodilation, the enlarging of those vessels above that level of injury. And then what's going to happen? Then you're going to get all of these symptoms. You're going to have that flushing, blurred vision. You're going to have that pounding headache. So early signs and symptoms. So what we're looking at is some of the most common ones. You're going to have that profuse sweating. You're going to have maybe goosebumps, the flushing of the skin above that level of injury, a pounding headache. But what's really scary is sometimes you can have no symptoms. You can just feel a little off. Ryan, can you talk about your first symptoms of AD when you were in the hospital? And did you really know it was AD? And the second part of this, when did you really find out more about autonomic dysreflexia?
So I ended up developing a stage 4 wound during my surgery process. And when I was in the ICU in recovery, I was always constantly getting cold. So I was requesting for sheets and blankets and just to warm myself up. So it was thought that with a bunch of these sheets and blankets on me that my sweating was due to me overheating. And it wasn't until I went into acute rehab that I started to learn that those sweating symptoms, which are actually symptoms of autonomic dysreflexia. So what was going on was that the extra weight from the sheets and blankets that were being pushed onto that stage 4 wound was putting pressure on it, and it was sending me into the AD symptom.
Thank you. And just looking at this diagram over here, so we're looking at anybody who has that T6 level in injury and above who are at risk for autonomic dysreflexia. But, I mean, it could be T7, it could be TA, it depends. It's not like an absolute cutoff. I've heard situations where we have a T7 individual who works for us who gets autonomic dysreflexia. So just looking at this chart here with this man on top of this dynamite, you can see that above that level of injury, you're getting vasodilation. Below that level of injury, you're getting that vasoconstriction. That vasoconstriction is really causing that blood pressure. So, I mean, it's just not a few things. You can see here, bladder, anything can happen as far as the bladder is concerned, an infection, and two, when you have constipation or an impaction in the bowel, what happens is you're pushing on that bladder, so it can create that urinary tract infection. Hemorrhoids, it could be just about anything. Ryan, can you talk about your recent episode of autonomic dysreflexia? Because you woke up in the middle of the night, and maybe tell the audience what exactly happened and how it was resolved.
Correct. So in 29 years, I've experienced all different little AD symptoms due to one thing or another, like an ingrown toenail. But the worst that I've ever experienced was a couple months ago that Margaret is referring to. And what actually took place was that I have two caregivers during the day, my morning caregiver and my evening caregiver. My morning caregiver had taken my bedside bag as I was getting up during the day and threw it in the garbage and went into the storage to pull out another bedside bag. What he didn't do is he didn't take the cap off of the tube and placed it into the basin. So when the evening caregiver came in, taking off the leg bag, she was not paying attention to the bedside bag and took the bedside bag with the cap on to plug it into the, I have a Foley. So plugged it into the Foley. I wasn't aware what was going on. She wasn't paying attention. I wasn't informed. that the bag was replaced. So as she left, about 30 minutes later, I started sweating, and then I started sweating more. And then I started getting a headache, and I started getting a pounding headache, and I started really getting nervous to try to figure out what was going on. I called my neighbor. My neighbor has never, in the 29 years, and I've known him for 35 years, to help me in any type of autonomic dysreflexia situation. Thankfully, I was able to walk him through what needed to be done, and as he was doing some troubleshooting, like, is there urine in the bag? Do you see any urine in the tube? Press on my belly a little bit, just trying to figure out all the little type of things that could possibly be going on. He noticed as he was pulling the tube for the bedside bag, it ended up plopping on the ground because the cap was still attached to the pulley. And that was an indication that it was just not, I was voiding, but it was not going through because there was that blockage. So once the cap was removed, then I ended up taking the bedside bag and reconnected it, and it was flowing perfect. My blood pressure was pretty high. It was around 130, which my normal blood pressure is not that. So we had to monitor it, and it really was a bad experience. It really knocked me out for about 12 hours of feeling like I was in a race.
Thank you. And that was really scary. I remember you telling me all about it, and you led us right into blood pressure. Because, if you're feeling these off symptoms, it's really important that you have a blood pressure cuff handy. Because, as I said earlier, you sometimes don't get symptoms, but you just don't feel right. So, basically with that blood pressure, you need to know what your baseline is. It's very important. Ryan, you have what's called an upper motor neuron bowel. So that's above that T10 and above. What generally is your blood pressure baseline?
So my normal mean is 85 and maybe high 80s, but anything in triple digit is definitely autonomic dysreflexia.
Yeah, so I mean, whether you're, an upper motor neuron or a lower motor neuron, it may be different. The lower motor neuron may be a little bit higher than Ryan is. So it's important just to really understand what your baseline is, because if you get into that situation, basically you need to resolve it. And this next slide will really help, sort of take you into the resolution of helping you determine, what's going on. So it's really important that, you follow this, because a doctor that we work with our company, he is a spinal cord injured individual. And he also, decided that he is going to put something together that's easy to remember. So basically sit the patient upright. Place the legs down. A lot of times you should think you should put your legs up, but that's not the case. You should place your legs down. And then loosen that tight clothing. Make sure that there's nothing really, hitting you at certain parts. Loosen anything, especially, people like wearing those skinny jeans. And then investigate. What you want to do is look at those key areas, which is number one would be your bladder. Basically with autonomic dysreflexia, almost 80% of the cases are a direct result of that bladder. So that blocked or kinked catheter. So look at that first. And then next, bowel about 20%. So, making sure it's not constipation or impaction going on. And, look at the skin, because the skin is really important, like that chart that we showed you. I mean, it could be anything. It could be an insect bite. It could be an ingrown toenail. And if none of this works, then basically treat with medications. So tips on preventing autonomic dysreflexia. Really, you should consult your healthcare provider for additional resources related to personal care. Keep those bladder volumes within acceptable range. You may need some additional medications to relax the bladder. Anybody that lives, I'm in Arizona, Ryan's in Florida, so we get that intense sun. So make sure that you wear sunscreen. And of course, those weight shifts. If you're in a wheelchair, even just picking yourself up from the wheelchair, makes a huge difference. And then if you're bedbound, every 2 hours to prevent pressure injuries. Now, Ryan, you're in a wheelchair, so how do you alleviate your body from this pressure?
Well, in the chair, I have a tilt in space that allows me to recline. I should be doing it every 15 minutes. I was reclined for a good probably an hour or so earlier to make coming on to this Zoom presentation. So I'm not going to be concerned about doing this every 15 minutes during the presentation. But I typically take the pressure off by reclining. In bed, certainly my air mattress helps with that, with a lateral pressure where it relieves from side to side. So that helps in assisting taking pressure off. But I monitor my skin integrity every day. I have my caregivers monitor it, even if it's a little red pressure spot, we monitor it and we try to figure out where did it come from. But I'm always on top of my skin integrity.
Thank you. So why is bowel care a concern? Again, I said it was the #2 cause of autonomic dysreflexia. You're looking at constipation, even during performing bowel care, you can get autonomic dysreflexia, hemorrhoids, fissures, those painful bowel movements. Now, Ryan, you've been doing bowel care for quite a long time, and you have been doing different bowel care routines. Can you talk a little bit about how you started out and where you transitioned to?
When I was in acute, first when I was going through all the surgeries, I was not on a bowel program at all. So it was about, there was something like 12 to 18 weeks until I finally, when I got into acute, to be on a bowel program. And that bowel program consisted of an enema called Therabac, which I did every other evening, which was referred to as shower night, and did that through the whole 3 months of acute rehab. Post-discharge, continued on with the same agent, the mini enema Therabac, but I decided to do it in the morning, so every other morning, using the mini enema. And for about 5 years after being reintegrated into the community, I ended up finding out that the Therabac was no longer available, not because it was a harmful product. It was just that the pharmaceutical company no longer manufactured that line. So my mother, being an RN, decided to use the over-the-counter large volume fleets enema, which worked, took a lot longer than the mini enema did, and both of them were causing sweating symptoms during the bowel program. But they was causing a lot more discomfort and dehydration than the mini enema did. So then we moved over to the suppositories, and they were generic. There was no brand name as there is today. So we're using the generic viscoelastic suppositories, and they took a lot longer to produce results. But what they were doing that the other two weren't doing was causing accidents or mucosal discharge hours later during the day or the following morning while laying in bed. And it was just something that I was not prone to with learning about program. When I was on a college course, I was that early morning, I was headed off to class after doing a bowel program, stopped to get a cup of coffee, was in class drinking my cup of coffee, and then I had a bowel movement, the second one. So I ended up having this humiliation. I was very nervous that the students around me and professor, would have smelled, what went on. So I left real quickly, and thankfully I met a quadriplegic on campus earlier that semester because I wasn't part of any support groups. I really didn't know any of the other new products that were on the market. So when I returned home, I called him up and asked him what he was using, and he told me about Enemies. Never heard of it before, so I went on the internet, saw that I had two choices of Enemies, which is the blue label, or Enemies Plus, and I figured Plus was a quicker, faster product, so I chose Plus, not knowing, which I know today, that the Plus has the additional benzocaine, And my bowel program went right back to when I started with the mini Theravac, because that's exactly what the Theravac is. It's just the regular enemies, but plus has the additional benzocaine, which totally alleviated my sweating symptoms during my bowel program.
Thank you, Ryan. And, can you talk about some of these red flags of an ineffective bowel program? Because I know that, you just explained that you had incontinence. And, in the past, when you were using other products, I mean, how long did that bowel program last?
When I started with the mini Theravac to where I am today, less than 30 minutes. The large volume fluid Cynomol was probably around 45 minutes to an hour, and the Theravac, not Theravac, the suppository was over an hour, but that was the one that was causing accidents.
Yeah, and essentially, I mean, you don't want to spend your day, worrying about, how long your bowel program is going to take. So it's important that, these bowel programs be 30 minutes, at the most an hour. And we have to be very careful about accidents, because as a result of the accidents or incontinence, then you can get pressure injuries. And, also an ineffective bowel program, you might have excessive gas. And the stool is hard, rocky pellets. And this is where we get into the Bristol stool chart, because it's important to have that nice, soft stool that's formed. And essentially what we're looking for is that type 3 or that type 4 stool. This really was developed by a physician in Bristol, England, and the whole purpose of this was to look at the transit time through our colon and the type of stool that was produced. So when you're looking at that type 1 stool, it's transiting in your colon for somebody that doesn't have a spinal cord injury about 100 hours. Now, if you do have a spinal cord injury, it's going to be a lot longer. Because you have more of a slow transit time. And then that type 7, it's just washing right through in about 10 hours. So what we're looking for is that type 3 or that type 4. Now, the Bristol stool chart, you can get an app for it, so you can track it. And, just knowing from, maybe week to week, you don't necessarily have to do it day to day. But, if you start seeing some incontinence or maybe some hard stool, then maybe your diet needs to change. Maybe, you need more healthy fiber in your diet. So, just really understanding what the stool looks like is going to be very important. When constipation is improved, you get fewer urinary symptoms and definitely an improved mood. So let's talk a little bit about neurogenic bowel and the hierarchy of interventions. So of course, down at the bottom, what we're looking at is, diet, fluid, lifestyle alterations. Maybe you might need an oral laxative. Ryan, you don't use an oral laxative, or have you ever used an oral laxative?
Yes, when I was in acute care, I was given Senecot. I am on 0 medications as of year 2000, which was 5 years after my injury. So today I have no oral supplements whatsoever. Everything is natural.
Yeah, and many times if you do have that slow transit time, it might be helpful, but like Ryan, he does not need an oral medication. And then of course, the next thing on the list would be rectal interventions. I'm going to ask you a little bit about DigStem a little bit later when you review how to use our products. So I'll save that for later. But basically looking at rectal interventions, you have suppositories and you have enemas, and then digital stimulation. Transanal irrigation basically is for anybody that has insufficient results with the basic bowel management. So if number 1 or number 2 doesn't work, then possibly transanal irrigation might be considered, but you have to be careful for anybody with that T6 level of injury and above because of the autonomic dysreflexia. And then you have the ACE, which again is a cone-shaped, very much like the transanal irrigation, where you put high volumes of water into your rectum. And basically, it is more for those individuals that have spina bifida, which have that lower motor neuron bow. And then you have nerve stimulation. Again, with nerve stimulation, basically, this requires spine surgery, and then you have your stoma or ostomy, and this should be like the last resort for anybody. So let's talk a little bit about some of the typical products that are out there. Again, you have your orals like your Miralax and your Phillips Milk Magnesia. The suppositories, basically the over-the-counter Dulcolax or the Bisacodyl generic suppositories, basically this is an irritant or a stimulant. You have the vegetable oil-based product, which is the generic product. And basically it takes about 75 minutes to start to work because it needs the heat to dissolve the outer layer. So, and then once the outer layer is dissolved, then the stimulant laxative will start working. And then you have the Magic Bullet, which is the much faster version. It has the polyethylene glycol coating, so it doesn't need the heat to dissolve. So it'll dissolve fairly quickly. And basically, you know, within 15 minutes to 60 minutes at the most. And of course, you have your large volume enemas that basically Ryan was speaking about. Large volume enemas are really meant for occasional use, and particularly if you have that T6 level of injury or above, you shouldn't be using those large volume enemas because of the risk for autonomic dysreflexia. You know, with these, it's sodium phosphate. So basically, you know, you have to watch out with anybody with heart conditions, you know, can cause serious kidney injury if it's used too often. And you have to worry about dehydration and electrolyte levels. Enemies, the mini enema has been around for 20 years now in basically top CARF, VA, and model spinal cord injury facilities. Enemies is 283 milligrams of docusate sodium, and it's very small. It's essentially, you know, like this. So it's a small, when you think of enemas, sometimes you think of those big fleets enemas, but it's a very small enema. And the beauty of this product is that it works very quickly. And I'm going to get into a little bit more detail here. So basically, the enemies functions as a hyperosmotic. So what is it doing? It's drawing moisture from that mucosal lining into the stool. The active ingredient is docusate sodium, and the inactive ingredients are polyethylene glycol and glycerin. So polyethylene glycol and glycerin help with that peristalsis, and also the lubrication that you get from the polyethylene glycol all work together to help for a natural bowel movement. The PVA guidelines recommend docusate sodium mini enemas over the glycerin mineral and vegetable oil-based Bisacodyl suppositories. And the enemies plus actually has the addition of benzocaine that Ryan was talking about. Ryan, do you want to talk about you know, the administration and how your caregiver administers the enemies?
Oh yeah, absolutely. So it's a very simple, quick process for anyone that's doing it for you. So due to my level of injury, shoulder and above is my movement, so I cannot physically do this on my own. I have a skilled nurse that comes in every other morning And the first thing that she does is that she makes sure that there is no hard stool. And the reason for that is, in using any type of product, you want to make sure that it hits the rectal wall so it works effectively. If there's hard stool there, you're basically putting, in my case, Enemies Plus, right into the hard stool, and it's not going to work effectively. So if there is hard stool, in most cases there's not, she'll use your glove and finger and to remove that hard stool at finger's length. In most cases, there's not that an issue. So then what she'll do is, as you see the diagram off to the right side, which is the Enemies tube, she'll twist the tip off, which is very simple just to twist off. And then she will then squeeze just a little bit where the tube is down at the bottom, where it says, in this diagram, it says Enemies regular, which will squeeze in that area, which will then let some of the contents come up through the shaft onto the top and then spill down a little bit onto the shaft. So when she inserts and she starts to squeeze, well, when she inserts, the shaft is actually lubricating the rectum anus area. And then when she starts to squeeze, and she'll continue to squeeze till she feels that all contents in the 5 ml are out. Once she determines that it's all gone, she'll then remove, because this is not a suppository. Then she'll throw in the garbage. Right around the 2 to 3 minutes after she removes, my bedside bag will I start to hear the urine, which means to me, and not for everybody, it means to me that my bowels have started to kick in, because in my case, Enemies Plus has effectively started, and then it kicks my bladder into gear, so I start to void and release urine. So to me, that's indication that's working effectively. And right around 20-25 minutes after she's removed the Enemies Plus, I start to produce results. And right when I'm done producing the results, she'll then do a ditch check to make sure there's no loose stool. Most cases I don't, but in the case that I do, she'll do a digital stimulation for about 30 seconds to get that loose stool to come down. When the loose stool comes down, I'm done. I'm in my chair anywhere between 10 to 12 hours a day. I don't have any leakage. I don't have any accidents. I don't have any mucosal discharge. So my skin integrity is dry. I don't have to worry about going out and about and having an accident and humiliation, as I did in that college course, and feel that I'm going to be embarrassed that people smell me, or I've had an accident on the floor. So I don't even think about that whatsoever. And I've been using the Enemies Plus since 2001, so for over 23 years now.
Well, thank you, Ryan. So just to understand a little bit about bisacodyl, I told you a little bit earlier that, it's an irritant, it's a stimulant, but actually a physician actually did a study with bisacodyl on the normal rectal mucosa. Basically, what happens is that it's going to stimulate your mucosal lining. So when it stimulates that mucosal lining, it's creating that irritation or that inflammation. And that inflammation can persist for 30 hours after bisacodyl. And this is evidenced by neutrophils. So neutrophils are those white blood cells that get in there and try to make everything better. And, they can actually, scope it and see what's going on. And it really mimics a mild acute colitis. Even if you were to stop bisacodyl today, you would still get mucosal discharge for up to 3 days. And that's exactly what happens when you irritate that mucosal lining. It's going to, have that mucosal discharge because it's being irritated. And sometimes even fecal incontinence, which you'll see over here. This study was done actually in a model spinal cord injury facility in California. And basically, they did a baseline study with bisacodyl to see what the incontinence rate was versus Enemies. And you can see a huge difference, 42% versus 3%. So how do you get Enemies? Well, we do have a patient assistance program if Medicaid does not cover it. We are on the VA federal supply schedule. Some private insurances will cover it. We have discount prescription cards such as the GoodRx, where you can get it reasonably as a prescription. The important thing is that if you want it covered, you do need a prescription. And then you can buy direct at enemies.com. So before I get into resources, I would like Ryan just to talk about the importance of having a support system. And, not only with your friends, but actually with a group. Can you talk a little bit about your support group and maybe some of the issues that you speak to and, and your mentoring that you do as well?
Yeah, so when I was injured in '95, there wasn't a support group around. Not that I was seeking one, I really didn't think of looking for one, even if there was one. So I basically it's just trial and error with my friends, able-bodied individuals, for years and years. So when I had this accident in college course, that was the first quadriplegic I really met in the community. So when he introduced me to Enemies really changed my life and improved it, and continues to allow me to do the things that I'm doing. And as Margaret mentioned, the support group, and Barry had mentioned earlier, I'm one of the co-founders of the Spinal Cord Injury Support Group of South Florida here in the southeast part of Florida. We do have 3 chapters: West Palm, Fort Lauderdale, Miami. And we have a great group of individuals that either here as Floridians and were injured, or have come out of state and have relocated, especially during the pandemic. Our group is, we have great camaraderie. We do have individuals in the past and this current where were taught something from years and years ago that they're actually continue to follow the protocol, or they no longer have the ability to obtaining a product or a piece of equipment. So our group is really great at resources, providing education, and providing even presentations of such to inform and educate individuals, which I wish I had back when I was initially injured, because I probably would have learned a lot. Our group is also an affiliate part of the United Spinal, which is awesome because that allows us to get a lot of great information from United Spinal, and also being part of the North American Spinal Cord Injury Consortium, resources from there, and the Miami project. So the bottom line is, like, we're a hub, and we got all these different spokes that just continue to feed us with information and provide it. As a mentor, learning over the course of what works for me and what works for others, I'm able to help individuals determine, as not just myself, but other individuals in our group, pairs and quads, provide resources as a mentee to the mentees. So it's a great opportunity, and it's allowed me to do great things such as Enemies. I got involved with Enemies 10 years ago when I was mentoring here in the state of Florida, and I was finding out that there was a lot of individuals that were coming out of acute rehab, and they were not, due to the fact of the lack of, not the lack, but the decreasing amount of time being spent in rehab. So I was 3 solid months. Others, were getting a month if they were lucky. So there's a lot of missed education. There's a lot of things that individuals are taught when they're in acute, but they just can't absorb everything because there's so much going on, and you're just trying to figure out, when am I going to go home? How am I going to pay the bills? Am I going to be able to, get around my house? Are the doors wide enough? There's so many different variables that are going on that you just can't remember everything. And with that said, these individuals were coming home and they weren't really being taught bowel and bladder. So when I'm mentoring and asking them, what they're doing, and they're telling me that, oh, I start get sweating symptoms or headache, and I just have my caregiver or my parents push on my belly, and whatever comes out and that feeling goes away, then I'm okay. And I'm like, wow, wait a minute, that's autonomic dysreflexia, number 1. But number 2, why aren't you intermittent cathing, or at least use an external condom cath? Why aren't you on a bowel program? What's going on here? So that's what got me involved with Enemies. And for the last 10 years, it's been education, and I'm very happy in doing so. And I hope that with this information, because autonomic dysreflexia is a very deadly symptom that those that are in that C1, T6, but as Margaret mentioned, it's not everyone has to be in there. You can certainly get symptoms as a T7, 8, 9, but it's an education piece that everyone needs to know, and not just us with paralysis, but our caregivers, as well as springboarding the education forward to clinicians and ER doctors and nurses. Because if you're not around a trauma center and are not aware of spinal cord injury, and you happen to have to go in because you have a fever of some sort, maybe it's just a mild UTI, and you are in a regional hospital, the likelihood is they don't know about autonomic dysreflexia. So it's key that you understand that so you can educate others so they understand as well.
Thank you. You brought up some exceptional points, Ryan. So let's look at some resources from the Christopher and Dana Reeves Foundation. Now let's move forward here. I don't know. Let me see down here. There we go. All right. So if you don't mind talking about this, and then I'll switch it to the next slide to show them the other side.
Yes, absolutely. So the Christopher and Dana Reeve Foundation, they provide, this is about the size of a checkbook or a check. Could be put in a backpack, a purse, and it's a good resource. And why that is because, as you can see from here, it explains the common causes. It tells what autonomic dysreflexia is. It gives a medical history of you as an individual, allergies, emergency contact, which could be doctor, could be family member. And if you go to the next slide, what a physician would need to know, like nitro paste, and why the patient is getting some of these symptoms, is an education piece to, even the ambulance, like the paramedic, the hospitalist, which is the ER doctor, some of the nurses, the director of nurses. This can certainly move forward, and I could just give you a very simple idea of how important this can be. Let's say I was being discharged from rehab today. I'm here in South Florida, and my family wants to bring me out to a restaurant. We're about 95 degrees here now. That's temperature wise, but when it comes to the feeling, we're about 100 plus. So let's say I'm over at a restaurant and I'm eating, and all of a sudden I start sweating. Well, to those that really don't understand autonomic dysreflexia, they could think that I'm overheating because of just the nature of our environment here in South Florida, when actually my bag may be filling up, or I have a lay bag, or the tube may be king that it needs to be emptied. So without them thinking about that, they're thinking, oh, Ryan's hot. Let's, put some ice on him. Let's give him a drink some water. Well, hopefully, awake and understand what's going on, that with this card, at least I can educate those who I'm going with that are not understanding autonomic dysreflexia, that this is what they need to look for if something, God forbid, were to happen. So let's say they have to call the paramedics. The paramedics come, at least they now understand that this card, and being able to know actually what these sweating symptoms are and what to look for. And then this card can be passed on to the ER doctor or the hospitalist. So then now the ER doctor or the hospitalist can now monitor and make sure, okay, we need to order nitro paste. Let's start working with the nitro paste. And director of nurses, while you're there in bed and the nurses are coming in, they can now understand and learn from what this card is. So this card is free. It can be requested from the Christopher and Dana Reeve Foundation, and they can come in packs if you have support groups, or if you're involved with organizations that you want to be able to spread this card to those. And it's a good education piece for those that may not understand autonomic dysreflexia and you want them to learn more.
Well, thank you all very much. And there were a few questions. Basically, Ryan is here, and if you're interested, send a message to Barry. And if you want to talk to Ryan a little bit more one-on-one, Barry will be more than happy to provide his email to you. And as far as hand dexterity issues, unfortunately, we've looked at trying to find some sort of device, but there is just nothing that works with our little mini animals. So I apologize. With hand dexterity, there's not too much we can do on that end.
Thank you, Margaret. Thank you, everybody. Any other questions out there? Feel free to raise your hand if you want to talk verbally. It's not a problem. If you have that ability. And as Gabby mentioned in the chat, that this everybody that was here today will get a copy of this presentation, and we edit it and tighten it up a little bit, so you get more of Margaret and Ryan and not me. That's the whole idea. Cynthia, you have a question?
Yes, I do. I am an incomplete T5, T6 paraplegic. I don't know if I've ever had AD before, and I don't know what I'm here to learn, So I don't know how much it would affect me personally.
Mm-hmm. Well, as we went through, there are definitely symptoms that you can, relate to if you had, basically that flushing of the face, or if you just felt off. That's why I always say, if you just don't feel right, make sure you have a blood pressure cuff to take your blood pressure, because know what your baseline is. And then if it goes, 20 millimeters of mercury above that baseline, it's an issue. So, if you're just feeling off, then take your blood pressure. That's the best thing I can say. Anything else to add to that, Ryan?
No, and that's where you first start off. So for me, like, let's say I'm 85 and then I start feeling a little off, as you were saying, Margaret. I may not have a sweating symptom. I may not be dripping sweat or have a pounding headache. But if I go to have my blood pressure taken at 85, which is my norm, then starts to look like 110, 115, then I have to start asking myself, well, what's going on here? So that's an indication right there, Cynthia, that you can follow from your normal blood pressure to when you start feeling a little weird, so to speak. Then if it goes, as Margaret was saying, 20 millimeters of mercury above what your norm is, then you're start setting into autonomic dysreflexia symptom. If you start getting some goosebumps, you start sweating, these could be indications as well. And next time you have, and hopefully you don't have any in the near future, but if you do have a urinary tract infection, which I think most of us tend to get from time to time, see what your blood pressure is then. See if you start getting a headache or any type of sweating or goosebumps, and see if those might be symptoms along with whatever you may be going through.
All right, yeah.
We have Joseph now has a question.
Yeah, just out of my own curiosity, because the reason I asked that question, my doctor had mentioned this product a few times, but dexterity was the problem. But I'm curious. I know you had mentioned that study about the accidents versus bisicotal suppositories. Is there any research on full emptying versus bisicotal? With the, I guess basically, I'm not a doctor, but with the peristalsis being caused by the bisicotal, does this product have the same, so that everything goes out and there's not like a little bit left over for the next day sort of thing?
Yeah, I'm not aware of that. Again, any comparisons we do have, been with bisicotal as far as basically time it takes to work and fecal incontinence. So, I'm not sure. Ryan, have you had any experience with bisicotal? I mean, you had talked about having bisicotal in the morning, a suppository in the morning, and then you had a cup of coffee, right?
Hours later, yeah. Unfortunately, with bisicotal, it's a irritant where it irritates your bowel, and that's where you end up having the movement, so to speak. And then as it sits there with me, it didn't fully dissolve where that it was released with the first time I had the bowel movement in the morning. So what happened was 1 hour later, as I'm drinking my cup of coffee, and it just stimulated my body with warmth and my bowels moving. Or maybe I was having gas. I don't know exactly what was going on within inside of me, but it triggered that bisacodyl that was still sitting there. That I had that second accent while I was in class. Where the enemies, in my case, enemies plus, there's no leftover. I mean, when I get out of my chair, I don't have, I've heard the term butt snot, all these other terms that go along with, which is the proper term is called mucosal discharge. So I don't have the butt snot. I don't have the mucosal discharge doing the MMEs plus. Everything is dry. So with cases of those using the bisacodyl, there is the butt snot, there is the mucosal discharge, or what they say, it smells like nasty eggs. So everyone's got their own way of describing it, but I don't get that whatsoever from the Enemies Plus.
Ryan, I have a question for you. How much does your diet play into this? I mean, I can speak personally. I'm not pounding down a big steak the night before a bowel routine. So I'm just wondering how much does that play into any, or does it affect you at all in terms of how you use the Enemies Plus?
Oh, absolutely. That's a great question. So I monitor what I eat. I do have some dietary restrictions where I'm lactose intolerant, so I have to be careful on that factor. But I'm not eating a gallon of ice cream and a bag of Doritos and going out and getting a big steak dinner with the mashed potatoes. I know what my body can definitely handle from day to day. So for example, tomorrow morning is my bowel program morning. So I'm not going to be eating tons and tons of food where then I'm going to have my bowel program tomorrow, or the case, let's say when I do have the bowel program tomorrow, I'm not going to have Thanksgiving tomorrow, food wise, knowing that my next bowel program is going to be on Monday. I will tell you though, during Thanksgiving, knowing Thanksgiving, I want to have the good foods, especially those that I can have that are non-dairy. I have my bowel program every Thanksgiving morning. I cherish the foods and have a great amount of turkey and whatever else that may be going on wherever I'm at. And then I'll have my bowel program again the next day because I know that I just enjoy those foods. But that's only one time a year that happens.
Okay. Well, we're at the end of our hour, and I want to thank everybody for joining us today. And as we said earlier, you will be getting a copy of this program, and then it'll also be posted on our NASCIC website where we archive all these great informational webinars. I was reluctant at the beginning. I must confirm that the information you heard today is not medical advice. So if anybody has any questions about their AD or potential AD, please see a medical physician and investigate that matter. It can be sometimes a very light and modest problem to something that's very severe and life-threatening. So we must respect it, as we have to do with all the conditions of spinal cord injury. Thank you, everybody, and thank you, Margaret and Ryan, for your
thought, Ryan.
Sure.
Yeah, one more thing I want to say in regards to what I failed to answer on your dietary. Water, fluids, and making sure that you have enough up or down approach, meaning fiber. So every morning I have some form of fruits. This morning I had pineapple and watermelon chunks. Every evening I have some form of vegetables, mostly a salad. So that helps with that up or down approach with my bowel program. But being here in Florida, I drink tons of fluid. I make sure I am hydrated as much as possible, because if you're on certain medications which will constipate you and dehydrate you, you have to make up for those fluids and able to have a proper bowel program.
All right.
Thank you, everybody. Thank you, Margaret. Thank you, Ryan. Take care.
Right. Take
Be
care.
well, all. Bye-bye.